Welcome to the final part of our explainer on Ménière's disease, based on the clinical review from Australian dizziness clinics. Today, it is all about action. We're going to cover a clear, stepwise guide to management and referral. Okay, let's dive right in. Our focus today is a really practical, step-by-step approach for managing Ménière's disease. And, just as importantly, we're going to get crystal clear on knowing exactly when it's time to escalate care and refer your patient to a specialist.
You know, we're starting with what is probably the single most important, practice-changing takeaway from this entire explainer. This one sentence is a clinical pearl we are absolutely going to unpack, because getting this right, well, it directly improves the long-term outcomes for your patients.
First things first, let's set some realistic expectations. The goal here isn't some kind of magic cure. It's really about control. Success, as defined by the 2020 guidelines, is all about getting a 50 to 70% reduction in how often and how severe the attacks are. And that's a crucial point to manage with your patient from the very beginning.
I find it's best to think of the management pathway as a staircase. We start every single patient on step 1. If that's not enough, we climb to step 2, and so on. So we're going to walk up these steps together, all the way from lifestyle foundations to advanced surgical options for the toughest cases.
So let's start at the bottom, on the ground floor. This is the foundation for every single patient: lifestyle and conservative management. What's great about these measures is they have a low burden, pretty much no side effects, and for a lot of people, they can be incredibly effective.
Okay, so 4 key things make up this foundation. A strict, low-salt diet is probably the most supported one. Then we trial a complete elimination of common triggers. We're talking caffeine, alcohol, nicotine, for a good 6 to 8 weeks to really see what happens. Managing stress and sleep is also vital, because we know fatigue is a huge trigger. And finally, a symptom diary. This is non-negotiable. It's the only objective way we have to track progress and justify moving up that staircase.
All right, let's move on up to the next step. So what happens when lifestyle measures just aren't cutting it? Say the patient is still having more than one disabling attack a month? Well, it's time to consider first-line pharmacotherapy.
The most widely used agent here is betahistine. You want to start at 16 milligrams 3 times a day, but don't be afraid to titrate that up if you need to. Now, the evidence is a bit mixed, to be honest, but meta-analyses do show a modest benefit. So here's the crucial part. You have to give it a proper trial, at least 8 to 12 weeks, before you can say it hasn't worked. The other established first-line option is a thiazide diuretic, something like hydrochlorothiazide. The whole idea here is to try and reduce the overall volume of that excess endolymph fluid. And just like with betahistine, you've got to give it a solid 8 to 12-week trial to really see if it's effective.
Okay, now let's talk about managing those acute, really disabling vertigo attacks. This is where we come back to that critical warning from the beginning, what the source material calls the suppressant trap. This is so important.
During a full-blown attack, agents like prochlorperazine or promethazine are absolutely the right call to control that violent vertigo and nausea. They can provide immense relief. But, and this is a big but, there is a huge, non-negotiable rule that comes with them.
You must stop them at 72 hours. Let me say that again. Stop at 72 hours. So why? Why is this so critical? Because chronic use fundamentally works against the patient. It actually delays the brain's natural ability to adapt, what we call central compensation, and it can predispose them to developing a really debilitating secondary condition called PPPD, which is a chronic feeling of unsteadiness and non-spinning vertigo. And this quote just hits the nail on the head. Using these drugs for maintenance or for cover between attacks is the single most common and most avoidable error in primary care. It actively harms the patient's long-term recovery. It's the very definition of a practice-changing pearl. So what about the patients who, despite a proper 3-month trial of lifestyle changes and first-line meds, are still having disabling attacks? For them, we move up the staircase to steps 3 and 4. And this is firmly specialist territory.
Intratympanic therapies, that is, injections through the eardrum, present a really clear trade-off. On one hand, you have dexamethasone, which is a hearing-sparing steroid that gives good vertigo control. On the other, you have gentamicin, which offers even better control, but it carries a significant 20 to 30% risk of causing more hearing loss. The choice here is highly individualized, and it's a deep conversation between the specialist and the patient.
And then, right at the very top of the staircase, for the most rare and resistant cases, you have surgical options.
These can range from procedures that try to preserve hearing, like an endolymphatic sac decompression, all the way to destructive procedures like a labyrinthectomy, which you'd only ever consider when the hearing in that ear is already gone.
So this brings us to one of the most practical questions of all. When do you refer? I want you to think of referral as your clinical safety net, making sure patients get the right care at exactly the right time.
This flowchart right here is fantastic. It really illustrates the decision process. You'll see there are two very distinct pathways: the urgent, same-day referral for red flags, and then the routine referral for everybody else with suspected Ménière's. So let's break down those red flags.
These are the signs that demand an immediate, same-day referral to an emergency department or to ENT. Any sudden, permanent hearing loss, any new focal neurology, a severe headache, those sudden drop attacks, or bilateral symptoms, these are not consistent with a simple Ménière's flare. These are emergencies until you can prove otherwise.
And for every other patient where you suspect Ménière's disease based on that classic pattern of symptoms, the standard of care is a routine referral to a vestibular specialist within about 4 to 6 weeks. Every single one of these patients deserves a specialist to confirm the diagnosis and map out a long-term management plan.
Okay, we have climbed that entire staircase. Let's take a moment and consolidate all of this into a final checklist that you can apply in your practice, like tomorrow.
Here it is. It's this simple. Step 1, lifestyle changes for everyone. Step 2, a proper trial of beta-histine or a thiazide if that fails. The absolute golden rule: stop vestibular suppressants at 72 hours. Refer all suspected cases routinely and refer urgently if you see any of those red flags. And always, always remember, our goal here is control, not a cure.
And that wraps up our 3-part series. We've gone from recognizing the symptoms to the diagnosis and now to management. The crucial point is that an informed clinician, one who sees the pattern, orders that key audiogram, and makes a timely referral, can literally cut years off a patient's diagnostic journey, and that makes a profound difference in their quality of life.
Thank you so much for joining us for this explainer. To explore more on this and other topics in vestibular medicine, please visit the Australian Dizziness Clinic's website. And hey, if you found this useful, please subscribe and leave us a rating. We'll see you next time.